Thank you to the ACC for this opportunity to prevent a case of fulminant native quadrivalvular endocarditis with root abscess and bilateral cerebral and cerebellar infarcts secondary to Aerococcus urinae. So quadruple valve endocarditis is rare and death is a common outcome. For multivalvular endocarditis patients who undergo surgical repair or replacement, the estimated 30-day mortality is at 12.5%. Aerococci are gram-positive bacteria that grow in clusters and can easily be misidentified with streptococci or staphylococci. Aerococcus urinae can also cause invasive infections in elderly men who have underlying urinary pathologies. In this case, the patient is an elderly male with controlled HIV and a history of prostate cancer status post-radical prostatectomy. He has no history of intravenous drug use, and he presented to the emergency department with encephalopathy and multiple falls. He was found to be febrile, tachycardic, and had a leukocytosis to 34,000, categorizing him as severe sepsis, and his UA was also positive for UTI-like features. Septic workup was initiated, and given persistence of fevers, there was concern for endocarditis. A transesophageal echocardiogram was performed, which demonstrated quadrivalvular endocarditis with vegetations involving all four valves and regurgitation of all four valves. There was also involvement of the intravalvular fibrosa and the aortic root with scattered phlegmon and abscesses. In addition, the mitral valve was aneurysmal and also had a leaflet perforation. The aortic valve had vegetations on all three leaflets and had a flail non-coronary leaflet. Eventual MRI showed infarcts in the bilateral, cerebral, and cerebellar hemispheres. Subsequently, his cultures did eventually grow Aerococcus urinae. The patient was given extensive counseling for surgical intervention. However, he declined surgery. His condition continued to progress and worsen, and he eventually began to develop conduction abnormalities as well as septic shock, and eventually ended up passing secondary to bradycardic arrest. Quadruple valve endocarditis is rare with few existing reports in the literature. Concomitant involvement of the aortic and mitral valves is the most common form of multivalvular endocarditis, with usually staph or streptococci as the culprit organisms. Multivalvular infections often result from sequential seeding or simultaneous seeding of priorly damaged valves. For example, in combined aortic and mitral lesions, an aortic regurgitant jet may damage the mitral valve, creating an endothelial damage that is ripe for seeding, or seeding may occur from direct contact of an aortic vegetation with the mitral valvular surface. In a prior case series of 48 patients undergoing surgery for multivalvular endocarditis, 2 of whom had quadruple valve involvement, 30-day mortality was 12.5%. Successful quadruple valve replacement or simultaneous replacement in pair of all 4 native valves in native infective endocarditis has been reported. There is also 1 case of triple valve replacement in the literature. There is 1 existing report of a successfully medically managed quadruple valve endocarditis. However, the invasive etiology was MRSA, and there was no abscess development in that case, unlike our patient. Aerococci are gram-positive bacteria which grow in clusters and are easily misidentified with streptococci or staphylococci. The true incidence of aerococcal infections is underestimated due to this fact. Aerococcus urinae is responsible for urinary tract infections and can also cause invasive infections like endocarditis in elderly men with underlying urinary pathologies. Aerococcus urinae has 2 virulence mechanisms. 1, it can produce biofilm on materials and can also induce platelet aggregation. Aerococcal endocarditis is rare, and the majority of published studies are case reports or series. The largest study on aerococcal endocarditis reported 16 true cases. The majority of all patients were elderly males with urologic pathologies, and all had left-sided univalvular involvement. It is more common in significantly older patients and in patients with a higher prevalence of cancer. However, the rate of embolic events and surgical interventions for univalvular aerococcal Aerococci endocarditis is similar to that for Veritin's streptococci as reported in this case series. We present the first case of quadrivalvular aerococcal endocarditis in an elderly patient with a history of prostate cancer. Aerococci can be misidentified and incidence of infections is underestimated. Aerococci therefore should be on the differential for elderly patients with urinary tract abnormalities who present with endocarditis.